trying to allow enough time for questions, I am going to get started. So my name is Jennifer Love. I am an assistant professor of emergency medicine and a medical toxicologist at the ICANN School of Medicine. I'm going to be moderating, for the most part, this panel. And the title of our panel, our didactic panel, is called Xylazine-Xposures in the Emergency Department, Hype or Hope. And like I said, this will be a little bit interactive. You'll hear from our panelists. We'll ask you guys some questions. There'll be opportunities for questions at the end. So let's get started. We have no conflicts of interest to report, but what I would say is that some of us do receive NIH funding for the research that we do, particularly from NIDA. So what is xylazine? For those of you who maybe don't know, xylazine is an alpha-2 agonist that has become an emerging adulterant in the opioid supply, largely associated with fentanyl, and that has really emerged in the last 5 years. Xylazine is not approved for human use. It is largely used by veterinarians for large animal anesthesia, and it's used in combination with things like ketamine or other opioids. But as I mentioned, it is an adulterant in the heroin and fentanyl supply. Structurally, it is very similar to things like dexmedetomidine, clonidine, some other medications that are approved for use in humans. And it has made its way into the lay press in articles such as the New York Times describing some of the health effects and its effects on the population of individuals who use drugs. Xylazine became something that I was familiar with when I was training in Philadelphia, and Philadelphia has really become the epicenter of xylazine in the United States. It started to emerge sort of in the mid-2010s, like around 2015, 2019, and really took off in the 2020s. On the right-hand side of the slide, you'll see the Health Commissioner report from 2022 that shows sort of the rapid acceleration from 2017 to 2021 in terms of detection of xylazine in opioid overdoses in Philadelphia among people who use drugs. And on the left-hand side, you'll see actually the most recent data from the Center for Forensic Science Research and Education, which partners with the Philadelphia City Department of Health, where they do substance testing of samples from Philadelphia and shows that almost 99% of opioid samples obtained in Philadelphia now contain xylazine. But xylazine is not just a problem in Philadelphia anymore, or not even in the Northeast area of the United States. It's really spreading across the country. This paper was published in MMWR as a press release in 2023, and it shows the rapid detection of xylazine in other areas of the country, and that's been in only the last 4 years. So what we want to sort of talk about are what are the emergency medicine, clinical knowledge gaps around xylazine that exist. We want to address some questions that we think you guys might be interested in, but then leave time at the end for any other questions that you might have for our panel of experts here. And at this point, I'll let them introduce themselves so that they can be familiar to all of you.
Hi, everybody. Can you hear me? Yeah, okay. Thanks. First of all those people in the back, there are 6 chairs up front, so come on up. Even if you have to leave early, it'd be more comfortable if you're sitting down. We're not scary, or we're not going to bite. But anyway, I am an emergency physician, also doing addiction medicine. I practice at the University of Pennsylvania, where Jen trained and where some of us practice and still work together. So we've seen this evolution of xylazine. We're excited to share our experiences with you. So we're just doing intros?
Yeah.
Okay.
Thanks. I'm Lewis Nelson, the chair of the Department of Emergency Medicine at Rutgers, New Jersey Medical School, which is in Newark, and a medical toxicologist as well.
I'm Rachel McFadden. I'm a nurse at the Hospital of the University of Pennsylvania in the emergency department, and I also work at Prevention Point, Philadelphia, which has a wound care clinic, a low-barrier harm reduction wound care clinic where we've been seeing these wounds since they first began to emerge.
I'm Tony Spadero. I'm a medical toxicology and addiction medicine fellow at Rutgers, New Jersey Medical School in Newark, and I was Jean Marie's resident, and now I'm Lewis's fellow.
Awesome. Thank you. So I guess to kick us off, a question for the audience. Raise your hand if you've ever taken care of an opioid overdose patient who has prolonged sedation after receiving naloxone. Can I see a show of hands? Up high, up high. Okay, so quite a few people. That's great. So in the spirit of true emergency medicine education, we start things with a case, and we'll talk to our panelists about this case. Let's say you have a 22-year-old male who comes in, has a history of opioid use disorder, and comes in after an overdose. He reportedly receives naloxone by EMS. You don't know how much. And his vital signs are what you see on the screen. And while you're watching him in the ER for about 6 hours, he's pretty somnolent, and he's not really waking up much. For our panelists, is this, or are there other features common to a clinical encounter in the ED for a patient who's using xylazine-adulterated fentanyl? What, in your experience, have you seen?
Yeah, I would say that this is a pretty typical case of a patient who comes in. Often we hear from EMS that the patient got 4 milligrams or 8 milligrams of naloxone, was maybe found cyanotic and blue, now has had some restoration of respirations, has adequate oxygenation and ventilation, but is still sleepy. In the pre-fentanyl era and the pre-xylazine era, I think we would call this a polysubstance overdose. So now I think we should still call it a polysubstance overdose. And the most important thing is somebody did something life-saving and salvaged his respiratory rate and, gave naloxone. Whether or not naloxone affects any of the other substances is probably less of a consequence. And what's most important, and the take-home message here, is that naloxone works for these fentanyl-xylazine overdoses. And you'll see in our hospital, we have access to the same drug testing that you have. But a day later, we can also do xylazine testing and confirm that maybe there was xylazine present in this patient. But the supportive care is really the most critical part. And so this would be pretty comparable to what we see. Essentially near normal vital signs, except for respiratory depression. We don't really see a lot of bradycardia and hypotension. When the patient does wake up enough, we could ask them about their history of substance use, if they're aware that there might be xylazine in their fentanyl, or what other substances they might be using, like benzodiazepines, or maybe being unhoused and not having slept for a week, or other novel benzodiazepines that we can't test for. So it's pretty common that this scenario has emerged, but it's being relabeled as a xylazine overdose.
I mean, one comment I'd add is that patients don't really know they're using xylazine. We do know, based on the lab data that many of you get from your health departments or police organizations, we sort of have a sense of what the epidemiology of xylazine in the fentanyl supply is, but any individual sample, the person really can't tell. So we attribute things like somnolence for 6 hours to xylazine. I think that's a misattribution, personally. There's a lot of reasons this person can be sedate. And even if we got xylazine testing in the ED, and most of us probably don't feel strongly about getting this testing except for epi purposes, because to get the result back tomorrow isn't going to be very helpful, except to try to piece things together. And honestly, even if you get the test back today, unless it was quantitative, and even then we wouldn't know what to do with it, it's probably not very helpful. But xylazine is short-acting. So the idea we're going to attribute it to a 6-hour sedation is probably, again, as I said earlier, not correct. Those that use it probably experience a more rapid onset of their drug use because it's quicker than fentanyl is in onset. It probably doesn't last long. It definitively does not last longer than fentanyl. And just given the whole pharmacology of fentanyl and how its pharmacokinetics in your body, it's probably the cause of prolonged sedation, not the xylazine. Right?
So a follow-up question for our panelists. Let's say you get this urine drug screen back. You give another 0.04 milligrams of naloxone to the patient, and the patient is still breathing, but remains somnolent for the remainder of your shift. Are you going to move forward with something like intubation, or are you going to admit this patient, or sort of what is your clinical thinking for the persistent somnolence and the results of this UDS?
How many people have a boarding problem? So the boarding problem helps us triage a lot of things. So we're sort of end up observing people for longer than we might otherwise. But I would say the typical patient that I would see, I would give a repeat dose of naloxone to, because I think it's helpful to know if they might wake up a little bit more. You never know how much intranasal naloxone actually gets in somebody's system. So if another 0.04 doesn't wake them up, I would probably stop with more naloxone. Put them on a pulse ox, maybe put them near a nurse's station or a clinician station, and plan to check on them, probably a lot in the first hour. And then after that, much like a patient with an alcohol intoxication, you periodically make sure that they are progressing towards being a little bit more awake, even though they might not be ready to be discharged, with the overall goal of discharging them with resources, having them be awake enough to have a conversation about next steps. But I would probably not plan admission unless there were some vital sign abnormalities.
Just a question, Jen, did you set up the situation where the patient was sedated or stopped breathing?
Sedated.
Yeah, because I do think, and we have to be really clear that the endpoint for successful naloxone use is not arousal, right? Not awakening, it's breathing. And so if the person still had a respiratory rate of 12, I'm not even sure I'd give more naloxone. I don't know what the endpoint of that would be. And you're right, the intubation, nobody would do that. But if the patient's breathing started to fall again, their respiratory rate or their volume, I think giving more naloxone makes a lot of sense. And you might need to give multiple doses. We tend to use capnometry and pulse oximetry on this group, because they do sometimes progress. I'll state it again, I think that most of the continuing and resedation in respiratory depression is due to the fentanyl. You have to remember how much fentanyl people use, relative to the amount that we give. We're giving people 50 mics, 100 mics. They're using 1, 2, 3 milligrams of fentanyl at a time, right? So they're taking just monstrous doses, which we don't really think the pharmacology of that drug right, because it's not the short-acting shoulder reduction dose that we give to people. When you use multiple doses, it effectively becomes methadone. It effectively becomes a long-acting opioid, right?
Yeah, I think I have a lot of residents here, and they usually have to call the tox fellow when patients are needing multiple doses of naloxone, and I usually talk through the case with them. Are they having, significant respiratory depression? Are they becoming worsening hypercarbia? Sort of patient-oriented outcomes that you're trying to reverse by giving more naloxone. Sedation alone really isn't an indication for, doing intubation or giving repeat doses of naloxone, because you could do real harm to the patient. And I think, sort of as the UDS result that sort of flashed up there is that the overdose epidemics really, we talk about an opioid overdose epidemic, but it's really a polypharmacy overdose epidemic. And whether it's the xylazine or the benzos or alcohol, there's many other substances that could be present that are contributing to the ongoing sedation.
Yeah, just one last comment, just to clarify what I was saying, because it may not, I know the pharmacists think this way. Most of the physicians probably don't like when I talk about pharmacokinetics very much. Scary term. But, remember that when you use fentanyl, for a shoulder reduction, basically what you're doing, you don't hear me? Is that what that means? Okay. Sorry. Okay, is that better? Yeah. At other sessions, it's been so loud. When you use fentanyl for a procedure, it's basically, in the blood, in the brain, and out of the brain. And then it sort of just goes away. A little goes into your fat, and you limit it over time. If you take large doses repetitively, that buildup in the fat could be fairly extensive, and that's because fentanyl is a very lipophilic drug. And then over time, it sort of leaches out, maintaining an elevated blood level for quite a while. Because the half-life of fentanyl is not the 30 minutes that it looks like when we use it clinically. It's rather measured in many, many hours. And so it takes a long time. And as it builds up, because of the persistence in that blood level, it could cause prolonged sedation. And it actually leads, and we could talk a little bit about this later, to a change in the development of dependence, right? Because it's persistently soaking the opioid receptors and allowing the dependence to get quite deep. And think about that milligram of fentanyl or two that somebody gives, if you gave it to any of us, we would die, right? And yet they use this multiple times a day and they're still alive. So they have a lot of tolerance and deep dependence.
Awesome. Let's talk about antidotes. We toxicologists love antidotes. So any thoughts about antidotes for xylazine? Should we look into them? Are there any available? Is this a future avenue for understanding and treatment?
You're looking at me? I'll hold the mic up. The antidote for fentanyl, and Jimmy said this already, for xylazine is naloxone, right? Even though it has no effect on the alpha-2 receptor and on the xylazine fentanyl overdoses are a problem because of fentanyl, right? Not because of xylazine. So I know we haven't gotten too far into this, but the idea of an antidote to something that doesn't really cause a problem is a nonsensical. Right now, in the veterinarian world, where they use xylazine as an anesthetic agent, they do have an antidote, right? It's called atipemezole, and it's FDA approved for use in animals. It would be somewhat equivalent to a drug like yohimbine or some of these other drugs that we have, tolazolene. Well, but we really don't need those, even though they are approved to be used in humans, not for this indication. We're treating the wrong problem, right? And I would argue that if you took somebody who was dying of a fentanyl-xylazine overdose and you gave them atipemezole, which would reverse the fentanyl, you would do nothing for that person. I'm sorry, I'm misspeaking. Yeah. And you reverse the xylazine, you would do nothing for the overdose because the patient's dying of fentanyl. Right? Does that make sense? So it's really naloxone to reverse the fentanyl. That's the antidote in this situation. So there are a lot of people out there who misguidedly are pushing for the FDA to approve atipemezole or some other antidote for use in humans against xylazine. Right? It's money that's not going to be very well spent because it's a necessary answer. For those that you know, flumazenil, right, which is conceptually an antidote for benzodiazepines, we really never use it. I'm sure most of you have never used it in your career. There's some very select indications for it, most of which would not be in the emergency department because it's an unnecessary drug that's going to treat a disease we don't really need to treat.
Awesome. All right. So we're going to move on to our next topic. Audience question. Our panelists have done a lot of speaking. Has anyone taken care of a patient with a xylazine-related wound? Hands up high. High, all the way up. All right, so a good number of people. So the first question I have for the panelists is, what is the incidence of xylazine-related wounds? Do we know?
We do not know. We wish we knew, and hopefully we will. But so xylazine has been linked to these characteristic wounds, which in Philadelphia have kind of literally become a visual stigma of xylazine exposure. But we don't know prevalence. We don't know kind of the conditions under which, exposure leads to wound formation. We don't really understand the mechanism either. There are a few proposed etiologies based on what we know about what xylazine does both locally and systemically, and I think probably the biggest culprits here are vasoconstriction, the direct cytotoxicity, which is compounded in combination with other substances like fentanyl and cocaine. But there have been a number of published cases and increasing number of cases and case reports linking xylazine exposure to these wounds. And what we know from those cases are, one, they tend to be on the extensor surfaces of extremities, and this is kind of demonstrated on that anatomical figure on the left, and this is from a case series we're working on at Penn, that they seem to progress pretty rapidly into complex wounds, and complex wounds kind of are a whole new or hold their own kind of challenges in terms of treating, which I'll talk more about. They do seem to require these resource-intensive hospitalizations, which, as we learn more, hopefully will become less so, but multiple services, multiple surgeries, often very complicated discharges. And there is a very real risk of permanent disability when they go left untreated. And then, really importantly, they've proven to be a barrier to people entering rehabs and detoxes and even OTPs. And so this is treating, accessing treatment for the underlying condition. And people get stuck in this really vicious cycle of having a wound and continuing to use and not being able to get real treatment for either of those things. And then certainly, these are large wounds. As you guys have seen, they're large, they drain a lot, they're really malodorous, so they really kind of deepen the social alienation people are already experiencing.
How quickly do these wounds develop? Is this just a few uses? Do you get to use it in weeks?
It's so interesting. We were talking about this earlier this morning, and I think it depends on so many things. Some of...
Sorry,
I'm sorry.
The question was, how quickly do the wounds develop? Is it after a one-time use, several uses, repeated use?
Yeah. And I think what we all agreed upon was it depends on kind of the potency of the supply, so how much xylazine is in the drug being used, the mode of consumption, so injection versus insufflation, and then is this person unhoused and therefore also experiencing exposure to the elements and poor nutrition, and what other substances are they using? So it really depends on a lot of things, but do you want to?
Well, I mean, I'll go out on a limb here and say I'm not completely convinced that the wounds are even due to xylazine. So she and I talk a lot in Philadelphia and Newark are about 80 miles apart. It seems like half the patients in Philadelphia have xylazine wounds, and we've seen a handful in our hospital. Yet we have the same amount of xylazine in the drug supply measured by the state police, right? So our patients are basically about the same with some differences. So it's not clear to me specifically that it's the xylazine. I'm not saying it isn't, because there are, as you've suggested, some mechanisms that will explain it. And it may be the route of administration, although we do believe that you don't have to inject to get a xylazine wound. It doesn't always appear in the spot you do inject, right? So some of the nasal users get wounds, or at least people who say they don't inject, right? We don't really know what people do. So there are other reasons, particularly, dirty drug supplies, other things that could be added that might be more regional, practices they use more regionally in terms of how people use drugs. As you said, there's some vasoconstrictive properties, and maybe there's some data that support there's some oxygen utilization changes in cells. It's very unclear what it is, but the thing we really discussed was that it probably doesn't happen. I mean, it's going to happen after a use, but it's not like every time you inject, you get a lesion, right? And we recently had a woman who injected into her thighs and didn't have any lesions in her thighs, but she had lesions in other parts of her body, right? So it's not specifically at the site of injection, and it's not every use. I don't know, you probably have more experience.
Yeah, I would say, when this first started happening in Philadelphia, I also thought this was part of people who use drugs have always had wounds. We've always seen skin abscesses. We've always seen cellulitis. But this is really different and fairly distinct. People didn't have the degree of progression of their wounds despite, wound care. So I think I started where Lewis is, and I'm much more, it's just in our emergency departments every day. We have an addiction medicine consult service that is 3/4 people being hospitalized for wound care and, coexisting substance use disorder. So it's kind of taken over our emergency department population. It's probably the biggest reason why people end up coming to the emergency department along with overdose. So it's very, very, my explanation is that I think locally our concentration of xylazine in our fentanyl drug samples has actually gone up. And I think that the concentration exposure is why medical examiners in Los Angeles are reporting xylazine in, their deaths, but that's like trace, and nobody has wounds. And then here, everybody has wounds, and, we're not sure how much it's contributing to overdose deaths, but it's the one part of xylazine that I'm pretty confident is different, and it's related to concentration and chronic exposure. The other thing, I'm not sure if Rachel made this point, but we definitely see it distal, or not even distal, just not necessarily at sites of injection, and then definitely from all routes of exposure. So it's really quite puzzling, but it's so prevalent now. I mean, just the emergency department may have 4 or 5 patients with these very characteristic wounds at any one time, waiting admission, and really sick from their fentanyl use disorder as well. 10 years ago, we have medical examiner data in Philadelphia with xylazine in all of the decedents, in like 25% of the decedents. But then I think it was just much more trace, and people weren't using xylazine and fentanyl together 12 times a day. That was xylazine and heroin. So I think that combination and the concentrations have gone up, and that's why the difference between what they're seeing in Newark and what we're seeing in Philadelphia, I think, is really concentration dependent.
Rachel, could you walk us through the slides, sort of with the common presentation of wounds? Because I know this is something that you've taken care of a lot of patients at Prevention Point, and are really familiar sort of with the progression. And just a trigger warning for people that there are some pretty graphic slides.
Yeah, and one more thing I'll add is one thing I've noticed kind of in the last 10 years is people lose their and I think this is because this, fentanyl brought this. People are using more times a day, and they just lose their vasculature so much more quickly. So then people already were having a hard time, getting a good hit, and then xylazine appeared, and whether it's xylazine or any of the other things in the supply, people are getting kind of the direct cytotoxicity of all of those things just anywhere they stick a needle. It's not really going, we say injection, but it's not intravenous often. So what we often see, wounds related to injection use tend to progress faster and are worse, although, as mentioned, and I'll talk more about this on the next slide, they can show up kind of anywhere, and even in the absence of injection. But what we'll see within a day to a week at the site of an injection is this dark purple, irregularly bordered blister. And usually the skin remains intact, but it might be a little boggy. And that is necrotic tissue under there. As that necrotic tissue kind of sloughs away from the epidermis and dermis, then you are left with either a partial to full thickness wound, ulceration, or which you can see in all 3 of these early pictures, just kind of converts directly into this thick adherent eschar. Still devitalized tissue covering a pretty deep wound bed. And then over kind of a period of weeks, those ulcerations coalesce and spread, and often that's worsened by a lot of drainage that kind of eats away at those surrounding kind of peri-wound tissue. And you get these very mixed wound beds, and kind of at their worst, and this is in the weeks to months to years, we are now treating people who have had these wounds since like 2020. You get these very extremely deep, full thickness, sometimes probing to bone and tendon. This is when people begin to lose motor and sensory function. A lot of devitalized tissue, which may overlay and kind of hide that you have exposed bone and tendon. And the necrosis can advance to the point that the distal limb is no longer salvageable, and that's when folks are getting amputations. The wounds that we see in people who are either not injecting or are just developing wounds in places they are not injecting look like the photos on the left. So they are these kind of serocrusted, coin-sized ulcerations, still fairly deep. Sometimes they have a palpable kind of pocket of kind of fluctuance underneath and will drain pus, even though they don't otherwise seem actively infected, and often on the hands and arms and legs.
Awesome. What are the current best practices for wound care in patients who are exposed to xylazine-adulterated fentanyl? And do you ever consider admitting these patients to the hospital? If so, why or why not? Mood lighting.
I can say one thing to that, and then I'll hand off. And I think, Jen, on the next slide, the Philadelphia Department of Public Health published a guidance for caring for folks with these wounds, which is the first of its kind, in January of this year. And this was after a pretty long process of working with multidisciplinary teams who are seeing these people in all sorts of settings. And the three things that I'll highlight about wound care for people is debridement is so important, getting that devitalized tissue off the wound bed so that it can heal from the bottom up, which is what wounds do. And we really, favor has really fallen on using autolytic debridement, so topicals that kind of optimize the wound bed, which works gradually and painlessly and are pretty affordable and easy for people to self-administer. Obviously need surgical debridement sometimes, especially, for instance, those complex wounds will need a surgical debridement, but tissue sparing, so not the kind of traditional kind of debridement. And Temple Burn is trialing some dermal substitutes in folks who are continuing to use and aren't great candidates for things like skin flaps and grafts. So debridement and then an antimicrobial in the wound bed, because that high bioburden is really and actually I think I forgot to mention this on the last slide, but these like really necrotic wounds have extremely noxious bioburdens, and that's like such a hard thing to treat, and even systemic antibiotics don't really well penetrate the bacteria in the wound. So you need an antimicrobial in the wound. We really like to use things like silver and PHMB, which are broad spectrum and cover a lot of the bugs we know to be fairly common in people who use drugs. And then frequent dressing changes, which can really help preserve the peri-wound tissue and minimize spread and help manage the odor and the drainage, which cause so much distress to people, and figuring out ways to get those supplies accessible to people.
So maybe to answer some of your questions. A lot of patients, Rachel works at Prevention Point. We've tried to create this pipeline where when she thinks a patient, who's had maybe 6 months of wound care, doesn't want to come to the hospital, finally has to come to the hospital, try to create a welcoming environment where we're going to be advocating to treat their opioid withdrawal and their symptoms of anxiety associated with potential xylazine withdrawal. So in general, in our setting, a lot of the patients who come to the hospital have already maybe exhausted their local wound treatment pathways and need to be admitted because they need a little bit more expert interventions, possible surgical debridement. But then you can imagine in a big health system, a surgeon sees a wound and thinks diabetes or thinks something else and wants to go in and excavate all of the tissue and be really aggressive. And we lose a lot of viable tissue from that. And that's some of the data that's emerging from the Temple Burn unit, where they're really trying more tissue-sparing approaches. So while we admit patients to the hospital, sometimes that can be detrimental because then they get guns blazing. The surgeons want to do this, but they only want to do it if the patient has, achieved recovery. So they'll talk about this big procedure, but then they won't actually do it on that admission. They're like, when they're stable and they'll come back, see me in the office. Now, that's not really going to work. So I'd say another caveat is that, stopping drug use is a wonderful goal. Reducing drug use is a wonderful goal, but should not be predicating the treatment for these patients. So that's something else you need to go forth and disseminate. We can achieve a lot of things in the hospitalization, but harm reduction needs to be a big component of it. We need to get these people in a limb salvage position. Some of these people are incredibly at risk of losing limbs. Many have lost limbs. So when you talk about amputation as the way to limit progression, our patients tend to leave, so that's really not the option that they want to hear. And a lot of patients who have been told that actually with good wound care do have limb salvage. So we kind of need to use the narrative of successful strategies to support our patients and also teach in this large health system a different approach for surgical care for these patients.
Awesome. So next we're going to move on to withdrawal. Audience question, has anyone ever cared for a patient complaining of xylazine withdrawal? Raise your hand if you've ever had somebody who said, I feel like I'm experiencing xylazine withdrawal. Oh, interesting. Okay, so for our panelists, Does xylazine have its own withdrawal syndrome? What do you think?
I don't think there's a well-defined xylazine withdrawal syndrome. I think anecdotally, if you ask a lot of patients, they'll say that they feel something when they have stopped using drugs. Granted that is when they have stopped using probably many different kinds of drugs, including fentanyl, including whatever other, benzodiazepines, other substances that they're using. I think this was from a survey that we did online from people who self-reported xylazine use, and about half of them said they did experience xylazine withdrawal, but you can see that most of the symptoms that they're describing are pretty subjective, and there's not really like a well-defined withdrawal syndrome like there is with opioids that we can rate on the COWS score. And so I think the mainstay of managing xylazine withdrawal is managing the opioid withdrawal, because all these patients are primarily using fentanyl with their xylazine. And I think some of it's also setting expectations about their withdrawal management. And I think a lot of people have anxiety that their withdrawal is not going to be managed, or that they're using new drugs and they're worried about stopping using those, and that their symptoms are not going to be addressed. And so I think it's important when you're at the bedside to acknowledge that the patients are going to be anxious about the hospitalization, going to feel like they're having a lot of symptoms that they're worried aren't going to be managed, and I think you need to reassure them that you're there to take care of them and manage those symptoms.
Does xylazine withdrawal complicate MOUD initiation in the ED? And should we be worried about if a patient reports xylazine exposure but also wants to start buprenorphine?
In Philadelphia, there's a lot of sentiment that buprenorphine doesn't work for fentanyl or fentanyl-xylazine. That's the same component of what Tony's saying, which is they're also worried about xylazine withdrawal. Many patients have told me that their xylazine withdrawal is worse than their fentanyl withdrawal. But when you try to pin them down on symptoms, as Tony said, it's really that anxiety and restlessness that can be a component of any opioid withdrawal, but is particularly prominent with fentanyl withdrawal because of their increased use and the shorter period between use where they start to have symptoms again. When we admit people to the hospital, we have an opportunity to see how all their withdrawal might go. We do use a lot of full opioid agonists. We do use clonidine. We use a whole bunch of other support medications to keep people as comfortable as possible. But what we've seen in chart review and prospectively is that everything to us looks like opioid withdrawal and responds with this kind of combination of treatment. We did do a chart review looking for a xylazine withdrawal syndrome, like looking for seizures, looking for hypertension and tachycardia, looking for all those things. And basically the breakdown is, we didn't see any agitated delirium or things that would look like a benzodiazepine or alcohol withdrawal syndrome. We didn't see seizures. We didn't really see vital sign abnormalities. 2 of about 75 patients had kind of an unexplained syndrome. Might have just been untreated hypertension to begin with. But we're really not seeing a fulminant syndrome that everybody gets. We're still working out, I think, the details of the discordance between what patients say, and we don't want to dismiss that, and what we're, objectively observing. But we can keep patients in the hospital when we are aggressive about full agonist opioids primarily, and then all of these other ancillary medications.
I want Tony to comment, because he's been ping-ponged between Newark and Philadelphia, and so you have some. But the one thing I would just like to remind everybody, and I speak a lot about pharmacology. There is, other than xylazine and maybe dexmedetomidine, there's really no alpha-2 agonist that we have that would adequately treat xylazine withdrawal. And many people reach for clonidine thinking there's some similarities in alpha-2 agonists. But I'll just remind you, clonidine is really an imidazoline agonist. It's not really an alpha-2 receptor agonist. If you think about the overdose concept, we didn't really talk much about this, but if you were to take a pure xylazine overdose, which is effectively what we give to animals in the vet world, or in a handful of human reported cases, one of whom I took care of a long time ago, was a veterinarian who tried to overdose with xylazine. This was probably 30 years ago. They don't really get hypotensive and bradycardic. It's a great sedative. It's dexmedetomidine, if you just think about how Precedex works in the ICU, or if you use in your emergency department. Clonidine obviously causes profound, or at least somewhat, hypotension and bradycardia, and they're really not the same. even though a lot of people link the two. So it would not be an adequate treatment for xylazine withdrawal. So again, I know I sound skeptical that xylazine withdrawal even exists, but if it did, the treatment would be an opioid agonist treatment for opioid withdrawal, because we don't really have a treatment for xylazine withdrawal anyway. So.
Yeah. I think there's a lot of anticipation of withdrawal, and I think this is kind of similar to what we see with precipitated withdrawal with buprenorphine. I know in Philadelphia, it was a hard sell to get a lot of patients on buprenorphine because they've heard of precipitated withdrawal on the street or they've experienced it themselves. And so it felt like all my patients in Philadelphia did not want buprenorphine. But in Newark, that seems to be less the word on the street, and we start many patients on buprenorphine. Some of them maybe have mild precipitated withdrawal and seem to be totally fine with trusting us and getting more doses of buprenorphine to treat their symptoms. And they seem to do totally fine. And I think there's a lot of worry and anticipation among patients with opioid use disorder that their pain and their withdrawal is not going to be treated while they're in the hospital. And I think, reassuring patients that their pain, their withdrawal, their anxiety, that their discomfort of just physically being in the hospital is going to be addressed, I think goes a long way towards alleviating some of those symptoms.
Awesome. We'll touch really briefly on testing options. Do you, for the panelists, think that it's necessary to test for xylazine? What is the role of testing for xylazine, either at a surveillance level or from a harm reduction standpoint?
I should have added that withdrawal chart review that we did was all in people that were confirmed to have xylazine present. So we do have the luxury of a big hospital with GC mass spec available. So sometimes it's nice to confirm either for the patient or for the clinician. But in a city where 98% of the drug supply contains xylazine, it's quite uncommon to not find it when you test early enough and look for it. So in our setting, I think it's not very helpful. We have been able to do some cool things like use xylazine test strips on human urine biospecimens that have confirmed by GC mass spec to be xylazine positive. And so hopefully in the future there will be a role for harm reduction organizations in places where there isn't so much xylazine to actually be able to use those test strips for confirming or discounting the possibility of the patients getting xylazine exposure. That might have actually helped your patient who you weren't sure if it was a xylazine wound. It's basically a rapid way of testing. But in terms of our patients in our community, there isn't too much of a role just because it's so prevalent. But, in places where there's a mixed drug supply, it could be very helpful for patients to, anytime you give a patient a tool to be more proactive, that's like a great harm reduction strategy. And they appreciate it. The test strips are about $1 a strip. Most of the states are just, giving them to us or to you to give out. So it really empowers patients to be able to use them to limit their exposures, which I would definitely recommend.
Yeah, and I'll just take a slight extension on that. Harm reduction is to reduce harm. I'm not actually sure there's harm from xylazine. And I think, Jen, you didn't present your data. I don't think we did. But, you have a great study that shows that people who had xylazine in their bodies at the time of hospitalization actually had a lower incidence of cardiac arrest and ostensibly a better outcome than those that didn't. And there was some other data out there from other groups that actually show that there's either no correlation with xylazine or it may actually be helpful. And it's a strong word to use when you're talking about substance use like this. So even if it were harmful, I guess my question is, you test your sample, it comes back positive. What do? Do you throw it out? You just spent $20 on this stuff. You cut it in half? Is half better than all? I don't really know what you do with this information. Right, so I'm not sure. I love the ideas that you brought up about how we could use it, but I just am not sure that we're not just sort of giving a false sense of security to people. Remember, with the fentanyl test strips, that was a big problem. Now that fentanyl is in 99% of all of our opioid, it's not useful, right? It might be useful for cocaine if you want to test that for fentanyl or something else, but there's probably not a lot of role because you just don't know what you do with the information. Rational actors might make a decision. Many of us, are rational actors, and if you just spent money on something, you're not going to just throw it out. Right, so I don't know what you do with that information.
Grace, you want to comment? Please.
Well, I guess thinking more broadly, I think point of care testing needs to be more accessible to all people using drugs everywhere. And that is because we have this extremely volatile and dangerous, unregulated drug supply. So as long as we're not putting, as much as we're not putting kind of effort into changing that, then we should at least make more information more available to the people who are facing whatever harms may or may not be coming from those substances. And I think xylazine test strips, the people in Philadelphia that have been, there was a recent publication on this that interviewed about the utility of drug testing, pretty universally want it. And I think, to your point, how they will actually use it, we don't necessarily know, but it's not really our business. I think it's good for people to have the information.
Awesome. Well, that concludes our questions for our panelists. Thank you very much. We now want to open it up to all of you who may have questions for our panelists, and we can pass a mic around so that everyone can hear the questions. I'll also just point out the QR code on the left-hand side will take you to a folder that has resources on xylazine, including publications, the best practices for wound care that Rachel described. And then on the right, the QR code, if you're able to complete this survey, would be super helpful for us and our group as we think about presenting information on xylazine in the future. Questions?
I wanted to ask about the dermatopathology of these wounds, because it seems to me that might help in understanding not only their cause but also their treatment. Is as you look at some of those, you think diabetic ulcerative causes, something similar to that, meaning ischemic related, but it could be ischemia. It could also be, when you talked about it, starting initially as a necrotic lesion that's isolated, then it makes you think more of an embolic phenomenon. So I'm wondering what work has been done to try to help figure that out.
In this case series that we are working on, which includes about 60 wounds, only one of them was biopsied, which I think this is a missed opportunity. I'll just say I agree. I think we could learn a lot from that.
Just to add, I know a few of the biopsies that I know about, and in speaking to the dermatologists, they basically said that it all is chronic inflammation and necrosis, and that they aren't seeing anything, but they also say that we need to biopsy them earlier to get that information, and we haven't done that yet. It's also, it's part of this other big health system with, multiple disciplines involved. So who owns wound care in a big health system? And it's a fascinating conversation that we're just starting to figure out. Vascular surgery, surgeons, rarely the dermatologists.
And people aren't presenting often with early wounds. That's, we'll see them in our low barrier harm reduction clinic, but not in the hospital. So I think accessing people at that kind of critical stage would be a challenge, not insurmountable.
It's on.
Just when you're speaking to, judicious use of antibiotics and, in Newark, we haven't had a ton of people with these wounds, and I've had one or two, and they've been kind of like borderline cases. Do you feel like it's pretty straightforward, having seen a lot of these people who, without being in just florid sepsis, do require antibiotics, and how often does that happen versus is it just this, cytotoxic pathway where you just need to do wound management?
I can say that our slam dunk answer as emergency physicians is to start antibiotics and admit them. Our ID colleagues are very excited about being really judicious, but most of these patients don't have sepsis criteria, even elevated white counts. They really have very little. They don't have fevers. Rarely do they even have surrounding erythema that looks different than just kind of the erythematous wound bed. It is often, there may be purulent granulation tissue. So I think our slam dunk reaction seems appropriate. When we get some evidence-based antibiotic guidelines, I think we'll chime in and stop using as many antibiotics, but I think it's also ingrained in our heads, like they need to be admitted to the hospital for what purpose? For IV antibiotics. So it all sort of feeds on itself. I think we really have a lot of work to do to figure out how to turn off the antibiotics. One thing that I'm sure all of you have is access to is other health systems. So like if a patient was at a neighboring hospital, 3 days ago, there's often pictures of the wound, there's a care plan, there's the MRI, are there deep tissues involved? And if we're, aggressive about doing those, chart biopsies, we can limit some of new therapies rather than just going along with a already multidisciplinary plan that was created at another hospital.
And just a brief extension on that. I mean, and when we look at it, and it's not this slam dunk sepsis picture, you look at this and it is a necrotizing infection. So are you giving like big, broad spectrum, treat this as if this is like a neck fascia almost, or?
I would say that we've probably moved away from a little bit. Everyone has a pretty good sense that these are subacute on chronic or just chronic on chronic, so less of that. And I think that was part of the initial slam dunk call surgery. We're trying to write this big health system pathway about who to call, and we're advocating not to call surgery at all in the emergency department, which is what they also want, because there isn't a need to intervene in those first few hours, days, weeks. It's much more subacute. But those are good questions. Thanks.
Mm-hmm. Hi. My question is, are people seeking out xylazine, or are they given an option, or is there like an addictive part that you think is xylazine?
I think there are some people that seek it out, and when we did that survey, there were some people that self-reported that they intentionally seek it out. I'd say we've had some patients that they say, on this corner, I know the person sells fentanyl, and on this corner, it's fentanyl with xylazine, and sometimes they try to avoid it, and sometimes they might not. I think there's probably a lot of reasons that we don't fully understand why xylazine's in the drug supply and why people might seek it out, whether it's for like a faster onset or to prolong the action of fentanyl, or if there's some sort of unique high associated with it. But I mean, I think anecdotally, I've heard patients say there's something different about the drugs they're using that they think has xylazine in it. And I think for some people, over time, they have started seeking it out.
I'll just offer a counter narrative to that, is that there have been a few recent either qualitative studies or survey studies published within the last 6 months, one out of Philadelphia, where they surveyed individuals about their substance use practices, and more than 50% of people said that they did not seek out xylazine, that they were actively avoiding it. And historically, I think when there was more heroin as the primary opioid, there is a lot of description in the past literature of people seeking it out because it quote unquote extended their high. But I think now, in the advent of fentanyl and sort of the change in how fentanyl accumulates and has like a rapid on-off, it seems like that has potentially changed people's perspectives. Although a lot of smaller individual qualitative researchers, we were trying to get better data and better descriptors of this.
Brian, University of Michigan. Great talk. I just had a question on the antidote for xylazine. You were talking about the mixed xylazine-fentanyl picture. You have patients who you treat the opioid overdose, and they're still sedated. Using that to help maybe with time to discharge, I didn't know your thoughts on implementing it for maybe that purpose, and also that sedation picture. What's their GCS at the time, helping as a clinician. The patient in front of you.
The problem is the reasons people don't wake up after an opioid overdose are multifactorial, and xylazine is probably one of them, but so are benzodiazepines, so is hypoxia, hypercarbia. There's a lot of other things going on. So it's really hard to know. And then we always worry about recrudescence down the road. We don't certainly know enough about how an antidote to xylazine would impact the clinical decision making. I do think that we'd be missing the boat because we still are worried about the fentanyl. If somebody woke up with naloxone and you watched them an hour or two and felt like they were ready to go home, that would be fine. If they got, naloxone and didn't wake up, you're not going to send them home. I'm not sure giving them xylazine, waking them up, and sending them home is going to really solve that problem, because it's still really the fentanyl that you'd have to worry about. The value question is important, because to bring this new drug to market would probably cost, a few $1 billion. And whether it's a worthwhile effort when there's so many other things we could do with that money, I'm just not sure it would be worth it. And by the time they got it to market, Xylazine probably won't even be here anymore. It is an adulterant. It's there for convenience. It's not, I don't think it's really not, despite what we just heard, I don't think most people really would prefer to use it if they had a choice. Right? It's used because it's a bulking agent. I don't really think it was added per se because of its psychoactive effect. It happened to have a psychoactive effect, which is great, as opposed to adding just mannitol or something, which doesn't. So I'm not sure I just don't think it's a worthwhile effort. If something existed, I would use the flumazenil argument. We could wake people up too, but we just don't.
My name is Ryan Feldman. I'm a EM PharmD in Milwaukee, and I just wanted to comment. There could also potentially be harms in reversal of xylazine. For instance, we've had patients who are chronically on clonidine take yohimbine from gas station supplements and get intracranial hemorrhages from it because it precipitates such a hypertensive crisis after. That's obviously a very small subset, but you are dealing with something that's going to cause physiologic derangements when you reverse them as well. And yohimbine is available as a drug. It's FDA approved already.
It is.
But I think most hospitals do not carry that.
Yeah. One thing, the FDA has come out with a lot of warnings about xylazine. Some of their material, like with the DEA, has been misguided. One group in OADCP, I think, called xylazine the most dangerous drug in the world. Right, and which is based on absolutely nothing. But the FDA in their announcement actually said, don't use yohimbine, right, or tilazine, because they're not, for the reasons stated, they're really not the right drug to use.
Is there no other, there's one other question in the back.
I don't know if there's a mic around here, it's pretty loud. Along those lines, with dexmedetomidine being theoretically being the correct medication to treat patients who are in withdrawal from xylazine, if such a thing exists, as has been hinted, has anyone tried or considered trying sublingual dexmedetomidine as an adjunctive treatment in the emergency department?
It's a money issue. I don't know. It's an expensive drug. It is available, so that's a fair question. Good study. Again, I think where we struggle is defining what xylazine withdrawal syndrome looks like. So then to know if we have success and what that would do to any anxiety-provoking sort of situation. To Tony's point, right, which is that so much of this might be expectation management more than it is a physiological effect.
Our substance use pharmacists at the Hospital of the University of Pennsylvania just published a perspective on using oral ketamine, which kind of, as a nurse on the ground, has been a total game changer for managing people's withdrawal, people using fentanyl and xylazine. And so I think maybe that's a less heavy lift in terms of getting that kind of approved and on formulary and getting nursing able to administer it, which we are working on at some of our other entities. And I have a question for you. The Philly Health Department just put out a health alert about medetomidine in the supply, and I wonder if that changes any of your thoughts on, I don't know very much about this drug. I know that it's also a veterinary not approved for human use, but if that would change any of your thoughts on an antidote.
No, but medetomidine is out there. Medetomidine is just the racemic mixture of Dex and Levo, medetomidine. But it has been found. The CSFRE, many of you know that group. It's a drug analytic group down in the Philly area. They've analyzed substances from around the country, and there is a fair amount of medetomidine in the drug supply, and it is an analog function, a clinical analog at least, and a structural analog of xylazine. So I don't know why it's being added, and maybe it's a deliberate decision because of its clinical properties, but it's still not clear to me, for people that work in the ICU or have, somebody could be on a Dex infusion for a couple of days. When you turn it off, they don't have withdrawal, right? So I'm not sure why we'd really worry about it.
All right, guys, I think we're out of time. Again, big round of applause for our panelists. Thank you all for coming.